I offer this presentation for its historical value. Intramedullary nailing of fractures with a very proximal tibia segment has been technically challenging from the outset. I worked for Synthase, the commercial implant representative of the AO Orthopedic Study Group, for 34 years, serving as Director, Advanced Clinical Applications. For 13 years, I also served on the AORF committee that reviewed AO research grant applications. I presented this material from the mid-1990s through approximately 2011 to orthopedic residency and fellowship programs and surgical groups. The original cases and techniques are now historical. The underlying lessons remain relevant. This is not only a surgical problem, but also an example of how confirmation bias can shape the analysis of a difficult problem. My name is James Green. I titled my presentation, Nailing Tibia Fractures with a Proximal 1/3 Segment, an Empirical Approach. This is not an art appreciation lecture, but I like this painting by Bruegel, done in the 1500s. It illustrates some of the issues we will confront. The builders wish to build a tower to heaven. They've built tall buildings before. This will be similar, just different in scale. They think they know the issues needed to be dealt with. They will ever so slightly incline the road, but the tower can still be made perpendicular to the road, as per usual. Unfortunately, the farther the project goes along, the more evident it becomes that things are going wrong. The workers seek answers from the experts, but they too are perplexed. Things have gone wrong from the beginning, because this project is different, very different. In the same way, nailing of a proximal tibia fracture is different from one more distal. Failure to understand this can lead the surgeon into a very nasty surprise. To understand the challenges of nailing a tibia fracture with a very proximal component, we will utilize empiricism, which is defined as an experimental method that's based on observation and experiment. Examples of quotes that are expressive of empiricism are, where observation is concerned, chance favors the prepared mind, by Louis Pasteur. Or, to see something, you have to be ready to see that thing. Another is, no exception should pass unnoticed, by William Cooley. He was an early orthopedist who observed that a few patients he was treating for sarcoma coincidentally shrank their tumors when they contracted erysipelas. But Cooley's toxins are another story. Interestingly, he is now considered the father of immunosuppressive therapy, and probably the most difficult to apply is the one by Marcus Aurelius. Question each thing of itself. Fractionating things when they seem whole is not easy, but we'll try to separate components and examine them separately. First, let's try to see the incidence of these fractures. In papers by authorities such as Lotties, Daubigné, Allers, and Friedman, going back to the 50s, we see a small but not insignificant number in this cohort of patients. However, when we probe deeper into what happens with these small groups when nailed, we begin to see some rather disturbing outcomes. Allers reported only being able to get 31% of them nailed without malalignment, or about 70% were malaligned. Friedman said that only 42% were not malaligned, which is a polite way of saying 58% were malaligned. In 1995, Lang reported on the results of nailing fractures with a proximal segment at Carolinas Medical Center in Charlotte, a very respected program. and they found that the results were so poor that it invited the title they gave to the paper, which is Proximal Third Tibia Shaft Fractures, Should They Be Nailed? The reason the question is poised is because 84% had angulation of 5 degrees or more in the frontal or sagittal plane. 56% had 5 degrees or more valgus. 25% had 10 degrees or more valgus. 59% had 1 centimeter or more distraction at the fracture site. 25% there was a loss of fixation. And 28% underwent exchange nailing, which is to say they had to have a second surgery to correct how bad the results of the first surgery were. The study out of Carolinas broke down the data with one particularly intriguing revelation. They identified the manufacturer of the tibia nail implants that were used. Those which are identified as RT would be manufactured by the Richards Company. Those identified as AO are made by Synthase. This is important because much of the controversy about bad results from tibia nailing would come to focus on the design of the nail. The two companies produced different designs. One had a very proximal bend, the traditional Herzog curve. It was used by Richards and many other companies. Then there was Synthase and the introduction of a novel design with a bend much more distal. The debate will swirl around where that bend is. What is overlooked is the most important data in the report, that is equally bad results were reported with both bends. It practically screams that technique is more important than design, but very few noted that. As the controversy began, we tried to understand what was happening with the entry site, and it seemed to be an entry site problem. In looking at these two specimens, which were done in 1993, we noticed one showed the classic malalignment and the other was anatomic. So what was the difference? At the time, it looked as if the one on the left had the entry tract directed more posterior, whereas the one on the right had the entry tract more anterior. We thought that perhaps the cancellous bone, in what we came to refer to as the anterior cortical pouch, was perturbing the entry angle of the nail, as seen here. The thought was that if we could evacuate the content of that anterior pouch, maybe we could nest the nail more anterior and prevent this malalignment. In the mid-90s, Synthase had an instrument for opening the intramedullary canal based on, believe it or not, its cheese sampler. The instrument was sort of a hollow chisel that could go over a guide wire. Because it was available, we thought we could use it to retrograde and remove the content of the anterior cortical pouch in this open fracture, as seen being done here. Unfortunately, this did not solve the problem in this case because of the larger problem that is occurring. We're seeing another common difficulty with these fractures. This is an excellent example of what a legendary surgeon at Harborview, Steve Bernershka, referred to as OIF, O-I-F. Instead of being open reduction internal fixation, O-R-I-F, it is only open internal fixation. Reduction has not been done. Very often these fractures are nailed without being reduced. About this time, a paper was published in the Journal of Orthopedic Trauma by Brad Henley from the biomechanics lab at Harborview. They believed they had found the answer for why the displacement phenomenon occurred. They termed it a wedge effect. They write, when the fracture location was such that the bend of the nail was within the distal fracture component, wedging of the nail resulted in significant posterior migration of the distal component during insertion. That is, the bend of the nail traversing into the distal segment will pry or wedge the segments apart. I want to bring attention to a critical part of their hypothesis which has been overlooked or ignored by most. That is, to have the hypothesis apply, the bend of the nail must go beyond the fracture line. I'll say that again. For this explanation to apply, the bend of the nail must go into the distal segment. I regret to say this paper should serve as a model of a very poor study that somehow made it through peer review. It contains no comparative sizes or different designs to test their hypothesis. Nevertheless, this study became the darling of those who believe the bend of the synthase nail explained the poor outcomes that were seen from many nailings of proximal third fractures. The belief became established that the problem with nailing a proximal tibia fracture had very much to do with the surgeon selecting the wrong nail design. As written here by Sanders, who states, they abandoned the use of this nail, AO, for closed, unstable fractures in the proximal third of the tibia, and now use an unreamed nail with a more proximal Herzog curve instead. Tornetta, a spokesman for a competing surgical device company, went further. He wrote, a nail with a very proximal bend should be used for proximal fractures. More distal bends in the nail will cause malreduction at the fracture site. This seems tantamount to saying a surgeon, by making an incorrect nail choice, is responsible for the bad outcome if one should occur. Another authority, Dean Cole, basing his opinion on the study of Henley, wrote, the greater the bend, the greater the translation. A recent study by Tensor et al. Showed a posterior displacement of up to a centimeter relative to the proximal segment when nails with a high degree of proximal bend were used. These papers establish the bias that is now thoroughly entrenched in the orthopedic trauma profession about the bend of the nail being the culprit causing adverse outcomes. No doubt about it. So it is no surprise when this poster exhibit appeared at the Orthopedic Trauma Conference in Los Angeles. I believe it was in '94. I found it to be very eye-opening. The poster is titled Anterior Unicortical Buttress Plate for Treatment of Oblique Fractures of Proximal Tibia Stabilized with the Synthase Unreamed Tibia Nail. It is by the group out of the University of Mississippi, and they show examples of what can go wrong. The authors assert that if a surgeon is going to use the Synthase unreamed nail on a tibia fracture with a proximal segment, they should use a supplementary plate to maintain alignment of the reduction. Both surgically repaired fractures in this poster are not really reduced. They are examples of OIF, open internal fixation. But the authors are oblivious to the most important message of their poster. It provides an example of confirmation bias. They cannot see the contradiction they present. The case on the far right is not a synthase nail. It has a traditional Herzog bend. This clearly shows the authors are so completely biased by the bend of the nail prejudice, they are blind to seeing their error. This is an example of confirmation bias before the phenomenon was commonly understood. The picture right in front of the authors was a repudiation of their title. Inverting the image lets us see more clearly how reality contradicts the Henley paper. For the wedge hypothesis to have application, the bend of the nail must go beyond the proximal fragment. Here the bend is contained completely within the proximal fragment, and yet there is significant displacement. The surgeon seems to have chosen the correct nail, according to the published opinion of authorities, but still, there is the common malalignment. Unfortunately, there's no AP view for us to see the displacement in that plane. By now, the bias is not merely in orthopedic trauma journals, it also is in orthopedic textbooks. This illustration was published in the Science and Practice of Intramedullary Nailing by Bruce Browner in the chapter on reamed and unreamed nailing of tibia fractures. It was authored by Sam Agnew and Brad Henley. Here is an illustration that nicely shows how the bend of the AO nail going beyond the proximal fragment and it's causing this displacement. But there's something a little weird with this whole thing. Again, this is a textbook, and so here it is opened. On the left side, where the proposed displacement is shown in a drawing, and on the right side we have a clinical example of what actually has gone wrong nailing one of these proximal segment fractures. Curiously, the bend remains in the proximal fragment. However, there is significant posterior displacement of the distal segment. There is a significant valgus also produced from the nailing procedure. How can the bend of the nail be influencing the displacement in both the AP and lateral views? How can anyone think that this is a design issue and not somehow related to an unexplained technique issue? So with all this discussion about nail bend, I decided to go all the way back and ask, why did the bend get put into a straight Künstner nail? Early on, they did use these Künstner femur nails because that's really about all they had. Here the rationale for the bend in a tibia nail is stated by Alms, which is, the upper end must remain slightly curved and therefore, if an unmodified nail is used, there's a tendency for its upper end to straighten out, especially in parotid bone. The trabecula can yield to this constant pressure and allow the upper end of the nail to migrate centrally, possibly damaging the articular surface and becoming impossible to extract. So, in a nutshell, the reason a bend was put into the tibia nail was not to fit the proximal tibia, but was instead designed so that it wouldn't have an elastic recoil that would cause it to migrate. Here the phenomenon of flexing or elastic recoil is demonstrated. The extension flexion results in migration of the nail through a sort of squirming effect. The reason the bend was put in the nail is to help keep it in place and make certain that it doesn't drift posterior in the posterior proximal tibia, making it impossible to remove, at least not without doing quite a bit of damage, possibly to the articular surface. AO Synthase wished to have a tibia nail design based on the intramedullary morphology of the tibia. They produced this design based on the same modeling technique used by Künstner. It utilized a compound that conforms to the shape of the intramedullary canal. The idea basically is to obtain the internal shape of the tibia and then model a nail accordingly. It seems rather straightforward, but this was brought out without any explanation or even acknowledgement of the work which Dr. Heine had done for his MD PhD thesis. I believe this work was done in Davos, but I never saw it presented. A novel design without explanation made for a very ripe scapegoat. And unfortunately, that's just what it became. But by now, there's so much information and bias that I thought it would be time for some new perspective. I think that is very well represented in this next slide. This photograph was taken in the early 1990s, and I want to assure the audience this slide is not about gas prices, Also, I'd like people to realize there's probably never been such a product for sale in Portland, Oregon as seen here. What I want to call out is there is something with this picture, or how we are seeing it, that is very confusing. Perhaps if we could change our perspective and see it from a new angle, we might have an entirely different take on the subject. And as can be seen here, if we can shift our viewpoint a little, things look quite different in this picture. And I think it's time to do that with the issue of nailing tibia fractures with a proximal segment. It is, as Marcus Aurelius would say, time to question each thing of itself. To break the components apart, let's begin with the position of nailing. It occurred to me that when a surgeon nails a tibia, they first put the leg into flexion on a fracture table. However, if plating, they put it into extension, the position of reduction. As I demonstrate here with a model I made in 1992, putting the leg in extension neutralizes quadriceps pull and facilitates reduction. This maneuver is hindered by the insertion instruments of tibia nails, which prevent the leg from being put into full extension. The problem at the time was all tibia nail systems had insertion instrumentation that obstructed that particular maneuver. In '94, I invented an insertion handle which permitted the surgeon to do this maneuver. I would like to emphasize I invented this handle. So far as I know, there were no other systems which allowed a fully inserted nail to be put into extension. Much to my disappointment, Synthase was not aggressive about patenting at the time and did not pursue obtaining one for this unique handle. I had signed a divestment agreement with Synthase, which means I lost out on getting the $1 silver given to inventors to hand over their invention. Synthase, though, lost out much more because they passed on having a unique claim that would have provided a market differentiation of great significance. I have to go on just a bit because having been around surgical instruments since 1964, I've always been taken by the simpler the design, the more elegant it was. It's a sort of Occam's razor. That which can be done with less shouldn't be done with more. So there was just a simple insertion handle with a driving cap and a targeting jig which moved along a rail track on the handle. Through this were put drill sleeves and then the locking screws. Very simple. Then it was a matter of demonstrating it was feasible and beneficial. Here is the first clinical use at OHSU. This procedure is being done by Andy Schmidt, who was a resident there at the time. He went on to have a great career in trauma orthopedics. Here is another example of the nail fully inserted and lateral to show that the knee joint is not being violated. As a part of the technique that was being evolved about managing these tibia fractures, we borrowed heavily from Jeff Mast and Reinhold Gantz's masterpiece on planning and reduction techniques in fracture surgery, which fully described the use of the distractor. The distractor answers the basic riddles of nailing tibia fractures. That is, how do you maintain traction while performing both extension and flexion maneuvers? Of course, with a fracture table, there is no extension maneuver possible at all. So the distractor provides some sorts of manipulation of the affected limb that are absolutely impossible with a patient on a fracture table. The distractor is an elegant mechanical device that allows the surgeon to focus the needed forces directly to the bone instead of applying those forces indirectly through soft tissues. Again, this simple method is beautifully described and illustrated in the Mast Gons book previously mentioned. I hope it is still in print. If not, even a brief glimpse is sufficient to convey how it is done. Indeed, the origin of the fracture table mechanism has a certain history. The forces produced have been reported by Kruger. It's understandable that impotence has occurred with femoral nailing and foot drop from tibia nailing. It is a very inefficient way of obtaining fracture distraction and comes at immense damage occasionally to the soft tissues. One modification we did make to the technique described by Mast and Gons was to use 6mm shank screws from the Wagner leg lengthening device. They never deform, which can happen with the 4.5mm shank pins, and the spear point lets them to be inserted through a small incision and turned directly into the cancellous bone with a moderate push. The physeal density can be seen here and is nicely observed on X-ray. The C-arm is brought in and the proximal distraction pin is placed under X-ray control. The same is done distally by tracking the physeal scar. The proximal and distal distraction pins are seen here, parallel to the joints. The distractor allows a figure of 4 position to be used for the procedure. This is easier for the surgeon than doing the nailing on a fracture table. Here we see Rick Rubenstein using the technique we authored in 1992, which helps substantiate some of the claims I will be making in this presentation. The figure of 4 technique avoids some more awkward and less controlled postures required when using a fracture table. It makes it much easier to do things like cross-table laterals with the leg out in full extension. It can sometimes be difficult to determine the exact length of the needed nail, and magnification guides have been supplied to help adjust for the magnification artifact. However, when the distractor is used, determining nail length is easily done by measuring the distance between the proximal and distal shank pins. The distractor is very helpful in dealing with an obese patient. In this case, the patient is on 2 tables. The radiolucent one is on her left side, and it is buckled to another non-radiolucent on her right side. Figure 4 and the use of the distractor also facilitates locking distal holes. The limb is supported as the surgeon applies dual pressure to perforate the bone. Not only can the distractor be used for traction, but it can also be used to compress fragments distracted during nail insertion. The distraction nut is loosened and the compression nut is tightened. The technique can also be used to overcome what can often be seen with distraction. Because of the way the force is applied unilaterally from the medial side, it is not unusual to see a valgus angulation when the fracture is distracted. The nail is inserted into the distal segment. With this done, the tip of the nail becomes the pivot point when the distraction force is lessened. When that happens, the valgus angulation is corrected and the nail is fully inserted. Another example, we see this occurring. The nail is inserted into the distal segment and the force of distraction removed and the alignment is corrected. Now to address the issue of frontal plane malalignment. As we've noted earlier, much attention has been given to the shape of the nail producing displacement seen in the sagittal plane. What is often seen but not commented on is how sagittal plane and frontal plane displacements occur simultaneously, which raises an obvious question. Why is there so much displacement seen in the frontal plane when there is no bend seen in the frontal plane? Here's a troubling example. The patient has films taken in the ER and shows a slight valgus angulation. The patient leaves the operating room with even more angulation now, fixed in position with an intramedullary nail. Not a good result to have the patient leave the OR with more angulation than they came into the ER. I began to wonder about the entry site as described in numerous papers and textbooks. Experts placed emphasis on not dividing the patellar ligament. The recommended entry site goes to the medial side of the ligament, as seen here in the illustration from Peter Trafton's article on tibia fractures. As I tried to find out why the medial starting point had become sacrosanct, I came across this interesting paper published in JBJS in 1962 by Michael Alms out of Saskatoon, Canada. In his paper on nailing tibia fractures, he did a study trying to determine where the entry point for their slightly modified straight Künstner nail should be. To do this, he did a retrograde insertion of straight drills from the distal portion of the tibia to see where it might naturally escape. As they found, it came out at the margin of the lateral articular facet, as seen here. That was quite different than the way I was seeing it being done. Based upon the 1962 Alms publication, we began to see the entry point was something different than was being currently described. We saw the lateral intercondylar eminence was in fact the better marker for where the entry point should be. We were happy to see this paper 2 years later by Tornetta et al. In it, they described the perfect starting point. They found in AP, 25% of the knees, the entry portal was lateral to the lateral spine, and in most, 75%, it was between the lateral and the medial spine. It was never medial to the medial spine. In other words, experts had been advocating the wrong entry site for years. There have been some interesting illustrations presented about how the trajectory of the nail can be directed. Some are quite misleading. In this paper, we see the wrong entry angle being shown on the left, letter A, and the diagram, letter B, where the surgeon really leans on the nail, it can be rotated into the correct alignment, letter C. This really isn't possible, and the reason for it will be addressed more thoroughly later in this talk. Here's an example of a nail that has been placed in on the medial side and fully inserted. There is profound malalignment seen in the frontal plane. Here's a demonstration of how critical the entry site is. The previous slide, which showed malalignment, is now corrected. The surgeon whom this was referred to needed to drill a completely new entry channel. The cavitation produced by the placement of the previous nail can be seen here with the red arrow. Placing the nail in along the correct pathway corrects the malalignment. Now to look at the issue of sagittal plane malalignment. In this example, many would think the reason for the malalignment is obvious. The surgeon has selected the wrongly designed tibia rod. As shown by Henley and advocated by many others, the AO rod with the more distal bend has caused this problem. Although the bend of the rod is not fully transversed into the more distal segment, its effect is already being demonstrated. But then, why should there be even more translation seen with the rod with the more proximal bend? Here the bend of the rod is clearly above the fracture, yet there is tremendous displacement seen on the lateral view. According to the experts, this isn't supposed to happen. Maybe the trajectory problem is because of the surgeon. Maybe the surgeon has failed to direct the nail correctly. Perhaps with enough cephalad push, the trajectory could be corrected from what is seen in A to what should be seen in C. As an aside, I will say at this point that the surgeon's likely lost control of the rod and the procedure at this point. As for why, I'll be coming to that later. During the course of lively discussion about the nailing proximal third tibia fractures, another aspect was addressed. What was the best way to acquire the entry site? This paper by Tanetta advocated a medial parapatellar incision with the leg in a semi-extended position to neutralize forces complicating the procedure. The authors believed this would facilitate a better outcome from a challenging surgical procedure. I thought it was interesting that the Tanetta technique seemed to look very much like the technique recommended by a French group who presented their work over 20 years before. Interestingly, the Tanetta paper made no mention of the work done by the French on the very subject decades before. Regrettably, I find this lack of scholasticism something that is often encountered with orthopedic papers. Also recommended by some is the need to place a supplementary plate to control the fragments during the procedure. Another example of that, and some have even used the pinless external fixator, although I do not know how long they left it in place and if they lost the reduction when they removed it. Perhaps having a couple of well-placed lag screws might do for the temporary stability. In our quest to find methods within the larger technique that might give the surgeon more control, we looked at several things. One was being able to control the fractured limb while the procedure was being done. There were many ways that were being used. Here, for instance, the surgeon is merely hanging the leg over the side of the table to try and maintain enough traction force with gravity. Not a reliable method, and one that invites compromising the sterile field. On the other hand, the distractor provides many benefits for the surgeon. In the territory that I dealt with, there were many rural orthopedic practices where there were no residents or partners available to assist. The distractor gave the surgeon enormous control and made it a one-person procedure. It made the figure of 4 position quite easy because it kept the fracture in traction while it was moved between AP and lateral views with the X-ray. In this position, it was very easy for the surgeon to check that they were placing the guide wire for the opening drill where they wanted it to be. Another advantage of this position is that there is no need to redrape between different X-ray views. Here is an example of what the surgeon is easily able to see. It confirms that the drill is positioned correctly and the nail will go where it must go to maintain the reduction. At the same time, where the surgeon is using an awl for the entry site is also easy to see that it is anterior and correctly placed. Here is an entry with the cheese cutter is going posterior, and it's easy to see that it is in the wrong position. It is being forced to go posterior, and we will see why. Here is where it is anterior and correctly placed. Here we can see the area of the anterior pouch if the surgeon wants to remove some of the cancellous bone. And how about the posterior wall? Some see the posterior wall as a potential skid that can be used to sort of corrome the nail tip off and back into the canal. But I have to ask, what would happen if the surgeon decided to use this back wall as a carom point? It certainly wouldn't have looked like this after the procedure ended. It is so anatomical that it is really hard to see, and the only thing that we can go by is the bit of a gap at the mid-shaft, which when we see in the healed views is exposed by the callus that formed about that site. Where the more proximal fracture was is absolutely unseen. And what if there is no posterior wall? Another of the many examples of what an AR-15 round does when it hits someone. There are millions of these war weapons in the U.S. A shooter with a gripe against a local investment firm went to their offices for vengeance. The first one he encountered was this unfortunate delivery man with no position at the financial company. Fortunately, the surgeon was able to get fixation, and his limb was salvaged. In another very open proximal tibia fracture from a traffic accident, we see another advantage of the anterior handle. By allowing the stabilized leg to be put into full extension, the limb is now in a position making soft tissue debridement much easier. Imagine trying to attend to this wound with a patient bound in flexion on a fracture table. Another issue that we noticed that is a common occurrence was these very proximal fractures is something we began to refer to as posterior latching. It seems the quadricep mechanism pulls the proximal segment into extension, and the distal segment is translated posterior. Muscle contracture shortens the fracture components, and the posterior tibia walls are now latched, making reduction very difficult. If it is looked for, it is commonly observed. With the distractor in place and the leg out in full extension, it is relatively easy maneuver to insert a Schantz pin into the more distal fragment, undo this latching, and reduce the fracture. Here is an example of the pin in place and the reduction occurring. It is easy to see the latching here, and also notice the bend of the nail is now beyond the fracture. If the surgeon hadn't noticed this posterior latching and reduced it, the post-op film would have been posted for others to see. You can bet that a number would say, "Oh, that is the AO nail. That's what's done it." Please notice this anterior fragment, which will help to identify this fracture as being the same one that we see now in the next frame. There is posterior latching. If left as we see it, almost certainly the malreduction would be attributed by some as being caused by the bend of the nail. Instead, it is unlatched, reduced, and anatomic. The bend had nothing to do with the malreduction. We can see the anterior wedge fragment and now no posterior latching. Notice that the bend of the AO nail is not the culprit. However, without this evidence, many would have found it guilty if left as it was. The proximal tibia on AP and lateral looks very capacious, but these two views are very misleading. They provide absolutely no information about what the cross-sectional anatomy of the proximal tibia is, and this is going to be critical in understanding what happens when the tip of the nail is inserted into the entry site. To look at the cross-sectional anatomy of the tibia, We section it in roughly 1 centimeter crosscuts. It reveals a surprising amount of change in a very short distance. Initially, it would seem the tip of the nail has a good deal of room, both towards the lateral and the medial sides. But as the nail is inserted, the space on the medial side quickly begins to shrink. The nail will encounter the medial wall and be deflected away from it to where there is more volume, which is to the lateral side. To illustrate the difference in volume of spaces in the proximal tibia, I give this example. On the left, I asked the surgeon to bring the curette as far forward in the central portion of the entry site as possible. Then I asked him to probe for the roof on the medial side. You can see that when the probe is on the medial side, as would happen with the tip of the nail, there is no way to bring it more anterior. The cross-sectional anatomy of the proximal tibia determines the trajectory of the nail. In summary, if the entry site is incorrectly located, the surgeon has lost control of the nail trajectory at the very beginning of the procedure. This brings me back to my example of Bruegel in the Tower of Babel. Once a wrong beginning is selected, it will be very difficult, if not impossible, to correct the situation. Loss of control at the beginning determines the result. And that is our hypothesis. AP and lateral views do not visualize the internal morphology of the proximal tibia, and it is the cross-sectional anatomy of the proximal tibia that controls trajectory of the nail. We summarized and presented our technique in our 1997 paper published in the Journal of Orthopedic Trauma. It was titled, "A Technique for Intramedullary Nailing of Proximal Third Tibia Fractures," and we described the technique as using an AO distractor applied to the medial side or a bilateral external fixator, the need to unlatch overlapping fragments. The technique summary is continued here. The entry site was to be as proximal as possible, in line with the lateral intercondylar eminence, hyperflexion of the proximal segment for nail insertion, a sagittal plane entry angle parallel to the anterior cortex, and the coronal plane entry angle would be parallel to the lateral cortex. Proximal locking with the knee in full extension. I would like to call out there was no supplementary plate fixation. There was no suprapatellar approach through the knee joint. There was no semi-extended approach. Most of these cases were done in small regional hospitals in Oregon by general orthopedists in the early 90s, over 30 years ago. Because pictures are worth 1,000 words, let's just go through the pictures. I cannot leave this subject without establishing one more challenge that confronted us in seeing this technique accepted. I'm showing here a letter which we had to write to the editor of the Orthopedic Trauma Society Journal to have our findings published. It had been rejected several times with the explanation that our technique offered nothing new. There were even some that said that we had plagiarized the technique. Fortunately, we had written a foundational paper in 1992 which proved that we were originators of this method. We acknowledged that we did borrow heavily from Jeff Mast and Reinhold Gans. They, however, describe only the distractor as regards the nailing of the tibia, nothing about the entry side or a series reporting on its use. What has been very disappointing is the shallowness of the scholarship on this subject. I'm putting this on YouTube because of the numerous papers I've seen which never mention the work that we did so long ago. Our method was so well established that we published a technique brochure that was distributed to the entire sales force of Synthase. This enabled them to walk through the procedure with the surgeon being confronted with this particularly challenging fracture. I was told by several sales consultants that this brochure had guided one of their surgeons successfully through nailing a proximal third tibia fracture. To conclude, I believe when all is said and done that what we really proved was what J. Otto Ladius said in the 1950s. When it comes to tibia nailing, drilling the insertion hole. This is probably the most important step in a nailing procedure. The enduring challenges confronted in nailing a tibia fracture with a proximal segment again demonstrates what history reminds us of. Surgical problems are not often solved by changing implants, but by understanding anatomy and technique. It also helps to know the history of a problem. It may have been solved long before you faced it.